Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. Wildhealth.com for all the information on becoming a patient or working with us.
Dr. Michael Mallin.
Dr. Mike Stone, how you doing?
Good, man. It's so good to see you.
Good to see you.
Hey, so cholesterol. We've talked about cholesterol a bit over the years. I think we actually did a pretty. I have a fond memory of you giving me an entire encapsulation of cardiovascular heart disease, atherosclerotic heart disease, in about a 9-minute or 6-minute segment not that long ago. But of course, we can't actually manage to talk about everything relevant, and have had a lot of people asking questions recently, largely because of topics that have been floating around in other health-related podcasts in the podcast sphere about apolipoprotein B. Mm-hmm. So that's what I want to pick your brain about today is ApoB. And from now on, we're going to call it ApoB because I don't want to say apolipoprotein B.
Yeah, I'll just fall over my tongue the entire podcast if we do that. Yeah.
If I need a buzzer button that I could hit every time we stumble on the full name. All right. So basic background for me. We've covered this before, so I'm giving you 30 seconds to tell me why traditional measures of cholesterol, like total cholesterol and LDL cholesterol, aren't enough. Maybe a minute.
30 seconds. It's like the podcast gets shorter and shorter. All right. Good question, Mike. So the main issue is that every cholesterol particle can be a different size, right? And the size of the particle has to do with how atherogenic it is. So smaller particles are more atherogenic, meaning they develop plaque inside the artery wall easier, mostly because they can be eaten by the inflammatory cells easier than the larger particles, right? So they also may potentially get through the wall easier as well. So get into the wall where it can turn into plaque and also get eaten easier. Now, the reason that's important is because your concentration is not a factor of how much cholesterol is in each one of those particles. It's just a factor of how much total cholesterol you have in your system, right? Whereas what we're really interested in is how many particles there are, because the more particles there are, the more likely you are to have plaque development. And also, what size are those particles, because smaller particles are worse. So you could have, for example, a lot of particles and a high total concentration, right? And then you would have a lot of big fluffy particles that aren't quite as atherogenic as the smaller particles, but you still have a lot of them, right? Or you can have a lot of particles with a very small concentration, right? And those are the scary people. Those are the ones that, don't get picked up by their physician because their LDL concentration is low, yet they have lots of particles, and they're the small particles, which are the ones that are more atherogenic. So the problem becomes, are we measuring total concentration? Are we interested in the total amount of cholesterol, or are we interested in the number of particles? And what the data has shown us is we should be more interested in the number of particles. And there's two ways to measure that. There's the LDL particle number, which is one laboratory measure for the number of particles in your system. And then there's ApoB. ApoB is a protein that sticks on the LDL particles. Basically, it sticks on other, type of particles like VLDL as well. But for this podcast, we'll just talk about LDL. And there's only a single ApoB on each particle. So we can measure ApoB as a surrogate for the number of total particles you have that are atherogenic. That was like 3 minutes, I think.
So yeah, I was, but I knew it wasn't going to be a minute. I just didn't want it to make it 30 minutes because I know you could go, and in a good way. So let me try and dumb this down for me. So I know the particle number is really important. The particle number is really often reflective of the particle size, and the particle number, a high particle number is a bad thing, right? A high particle number means you're more likely to have smaller particles that are going to get into the wall and be eaten by macrophages and turn into atherosclerotic plaque. The ApoB, as opposed to measuring LDL particle number, VLDL particle number, small LDL particle number, ApoB just gives you a single measure you can look at that gives you a sense of what your cholesterol associated cardiovascular risk looks like. Is that a useful yet dumb enough way to look at it?
Yeah, there's two things here. So you're talking about two different types of tests. One is a particle number test, which we've done on our patients in the past. And then the other is just the ApoB test, which just looks to see like what's the total number of particles, including small LDL, big LDL, VLDL, all the LDL particles, right? The ApoB, you can get a sense for how large the particles are by looking at both ApoB and LDL concentration at the same time, right? So if you've got a high ApoB and you've got a low LDL concentration, those are small particles. If you've got a high ApoB and a high LDL concentration, those are large particles, right? Whether we should check for LDL particle number, or for ApoB is really a matter of preference by physician. In my experience, ApoB is one, cheaper, and two, more consistent than looking at particle numbers. And that's just a function of the type of test that we use to check for particle numbers. So in my experience, we've done better looking at ApoB number rather than LDLP or VLDLP or small LDLP or one of the other particle number tests.
Got you. So if you had to have 2 or 3 lipid results to look at, I'm guessing here, you'd want LDL concentration, ApoB, and triglycerides.
Yes. If I had to pick
Boom.
3.
Nailed it. Nailed it. Yes. Yeah.
Can I
You
have,
only
can
get
I
3, Mike.
Can I get 4?
Can I have 4? Please, can I have some more?
Yeah, 3. If I had 3, those would be the ones I'd be most interested in. Yeah.
I love it. All right. So, in terms of, we know that early intervention to prevent cardiovascular disease is important. And the reason we know this is because you taught me this, that cardiovascular disease, like atherosclerosis development, one of the key factors is time. Right. So if we're able to intervene and reduce the lipid associated risk earlier in life, we're less likely to develop atherosclerotic heart disease. What is your goal, ApoB?
It really depends. Unfortunately, there's not just like one number that's perfect.
I knew it would.
Realistically, lower is better. The data, like at least looking at patients who have genetic mutations that cause, really low LDL levels, those people do perfectly fine as far as we can tell. And they have very, very low risks of cardiovascular disease. So the lower the number, the better. What is low enough depends on what your risk factors are. So if you have a family history of cardiovascular disease, if when we run our genetic tests on you, you've got a high genetic risk of cardiovascular disease, those are people that I'm going to want to have at a lower ApoB level, like out the gate. The sooner we can get it low, the better, right? Because like I said, it's a disease of time. Over time, they will eventually develop plaque. Even if their endothelial function is amazing and their inflammation is 0, they're still going to develop, some amount of plaque over time, because it's never going to be perfect, right? So, if I had to throw a number at you, I would say otherwise healthy human being, with a goal of longevity, I'm looking for an ApoB of less than 90. If someone has known cardiovascular disease, meaning they've got plaque in their arteries or they've got a high family history risk, those are people that I'm going to want less than 70, less than 60, ideally is where we're trying to get them with either medication or lifestyle intervention or whatever it takes.
All right, cool. Well, I don't want to turn this into another masterclass on reducing atherosclerotic cardiovascular disease risk, but give me your short version, your condensed version, because you just mentioned medications and lifestyle changes. So why don't we start with lifestyle changes, top 3 or 4 lifestyle changes to help people lower their ApoB?
So the biggest one is definitely going to be reversing any insulin resistance. So we see high ApoB levels in people with with insulin resistance. And that's basically because those people produce smaller particles, right? They produce more particles and a smaller LDL size, which means to carry the same amount of concentration, you need a same amount of concentration of cholesterol or triglycerides, you need more actual particles. And part of that is because their triglyceride levels are elevated, right? So higher triglyceride levels means that you have to produce more cholesterol in order to fill up these particles and send the triglycerides out to be used within the body or to be stored in the case of insulin resistance. So that's definitely the biggest one, is reversing insulin resistance. And that's, a huge problem when it comes to cardiovascular disease, because it is affecting not just cholesterol levels, it's also affecting inflammation. It's also affecting endothelial dysfunction, which are, if you remember from the last time we talked about this, the three main causes of cardiovascular disease, cholesterol, inflammation, and endothelial dysfunction. So insulin resistance, big one. If I had to choose another one, it would be reducing saturated fat intake. Now, this isn't necessarily required in everyone, and this is somewhat genetically determined, whether you're somebody who is a responder to saturated fat. And by responder, I mean, if you eat higher levels of saturated fat, then you are going to produce more cholesterol. There's, multiple SNPs that we've identified that are associated with this. And we check this on our patients, obviously, but, we can figure out which patients are going to more likely to respond to reducing saturated fat in their diet and then having lower cholesterol levels. So in those patients, I'm shooting for, ideally like less than 25 grams of saturated fat a day, which is not easy. That's a pretty low level of saturated fat, but it's certainly not somebody that you want waking up and having, 2 tablespoons of butter in their coffee, for example. Like that's going to cause a lot of problems when it comes to your lipids. So those are probably my two biggest ones. Within that, I'd throw exercise. It is helpful for sure, more in the sense of reducing insulin resistance than it is for cholesterol levels, but I always like throwing exercise in there when I can.
Best medicine in the world. Mm-hmm. Maybe next to sauna, which is a seated form of resting exercise. So sauna
is a good one for cardiovascular disease as well, as you mentioned it. Like, in terms of like what can you do to, and lifestyle factors you can do to reduce your risk of cardiovascular disease. Sauna is huge, right?
Yeah, I'm not sure that we have any evidence on sauna specifically having an impact on ApoB or your or dyslipidemia in general, but certainly from a all-cause mortality or a cardiovascular mortality standpoint, and from a hypertension standpoint, which we know is a key contributor to endothelial dysfunction and atherosclerosis, is definitely valuable. All right, so we've looked at, I'll play the patient. My ApoB, it isn't really anymore, but I'll say that my ApoB is 150, and I'm eating a ketogenic diet. I have multiple SNPs that tell me I shouldn't be eating a ketogenic diet, and I've got some mild insulin resistance, not quite prediabetes, but close to it. How are you going to... number one, I would just say these are things that we look at, and they're pretty easy to measure. Actually, from an insulin resistance standpoint, we'll look at things like hemoglobin A1C, but we'll also look at triglyceride HDL ratios, fasted insulin levels. We may look at a continuous glucose monitor from the is keto right for you, or is a high saturated fat diet right for you? That's really genetics and labs that'll lead us towards making a determination there, and that's very patient dependent. But let's say that I'm doing all the things you want me to do. I cut my saturated fat down to 20 grams a day. I'm exercising regularly, and I'm doing some, improved nutrition on the insulin resistance side. I've cut out simple sugars. I'm doing some fasted early morning cardio, maybe some time restricted feeding. You check me again, and my ApoB is 130. Right. So I dropped it 20 points, but it's still pretty high. And, I'm not quite 50, but I'm inching up on it. And you're going to move next to presumably a pharmacologic agent to help get my ApoB down. What's your approach to pharmacologic agents? Where do you start? What kind of leads you one way versus the other?
Great question. I like the way you presented that. You presented it as in we've basically done everything we can from a lifestyle standpoint, so we're stuck. And in order to get your risk lower, we need to turn to pharmacology. I assume that at 130, I think independent of history of risk factors, I'm gonna want to get that level lower, unless maybe you said you're somebody who we have a prior, coronary angio on or something, CT angio, and I know that you have zero plaque. If you have zero plaque and we're sitting at 130 and you're, 55, 60 years old, I don't think I'm really that interested in pharmacology, to be honest, unless your goal is to live to 120, sure. In which case that we should probably worry about it. But, but if you're in your 30s, that's definitely somebody that we want to be treating, right? So how do we go about deciding what to use? There's, three main classes of drugs. There is the statins. There's ezetimibe or Zetia, which blocks cholesterol uptake, and then there's the PCSK9 inhibitors, which basically increase reabsorption of cholesterol from the blood. Statins also, they work in two ways. They reduce production of cholesterol in liver cells, but the main reason that they actually reduce cholesterol levels is because they increase LDL receptors on the liver cells, so they increase absorption from the blood as well. Ideally, we would have a sense as to why your cholesterol is so high. I mean, ApoB of 150 is pretty high. I mean, we're in the FH range there, right? Familial hypercholesterolemia. So one thing I would do is I'd run some genetic testing on you to see if you have one of the particular SNPs associated with FH. There's a few of them that have a really high risk of FH and higher cholesterol levels that help us understand why your cholesterol is elevated, right? Is it because your body produces too much cholesterol? Are you an overproducer? Is it because you're an overabsorber, right? Or is it because you're an under extractor? So is it because your liver's making too much? Is it because your gut's absorbing too much? Or is it because you're not pulling enough out of your blood, right? And if I know those things, then I can basically personalize the pharmacologic care, right? If you're an overproducer, I'm going to be leaning more towards statins as probably a goal therapy, right? If you're an overabsorber, then Zetia might be a really good first-line treatment for you. And then if you're an under extractor, then PCSK9 inhibitors might be the best way to go. Now, it's not that simple, obviously. There's other problems, right? Like, so some people have genetic predispositions to getting the myopathy associated with statins, so we're less likely to go towards statins. PCSK9 inhibitors cost $600 a month. So somebody who doesn't have an extra $600 to burn a month, we might not be going PCSK9 inhibitors. And then if you're not an overabsorber, then, Zetia might not work that great for you, but otherwise Zetia is pretty chill and doesn't cause a lot of side effects. So those are the first things that I think about. If I had my way, I would lean on PCSK9 inhibitors a lot more than statins or Zetia, just because they've got a really elegant mechanism of action and are phenomenal at lowering LDL cholesterol. Statins come with a little bit of risk. There is the risk of myopathy, which is pretty big. Something around like 10 to 15% of people get muscle pain associated with taking statins. There's also some difficulty with funny that I'm having trouble coming up with a word. There's some difficulty with word recall associated with statins. And that's something that kind of freaks me out a little bit, especially in my ApoE4 patients. There has not been good data yet to suggest that statins can increase your risk of cognitive decline in any way, even in E4 patients. But I am cognizant of the fact that most statins do cross the blood-brain barrier and reduce cholesterol production. And one of the possible mechanisms for action of E4 in causing Alzheimer's disease is a reduction in cholesterol production in the brain. So something I definitely think about when I'm working with my patients. And then, so I basically try to come up with, one more problem. The statins also can cause diabetes. So insulin resistance is a not that uncommon side effect of taking statins. So something that needs to be monitored pretty closely by your patient or by your physician if you're starting on statins. So taking all that into account, you try to basically paint a picture of your patient, understand what are their risk factors. Am I worried about, dementia? Am I worried about insulin resistance? Do they have a genetic predisposition for myopathy? Taking all that into account, you start to paint a picture of like, how are we best going to place this patient on pharmacological treatment?
I love it. One last question for you, and we'll put this foray into lipidology behind us. Talk to me a little bit about the role of pharmacogenetics. with regards to selecting a statin for a patient for whom you've decided, hey, this is somebody that I want to get going on a statin?
So the statins, as far as pharmacogenetics go, there really is just risk for myopathy or no risk for myopathy or lower risk for myopathy based on the pharmacogenetics. Those don't place too high of a preference towards the different statins, to be honest. Now, you are more likely to get myopathy with certain statins. You know, there are certain statins that are going to increase the risk. Simvastatin, for example, is fairly high. And there's some that seem to be lower for your risk of myopathy. Like pitavastatin, for example, has a lower risk of myopathy. So, you know, I tend to go slower and go with those statins that have a lower risk for myopathy in those patients. And there are two hydrophilic statins. Two hydrophobic statins. There's two hydrophilic statins that don't cross the blood-brain barrier.
I go back and forth on hydrophilic, hydrophobic. So just for the listeners, hydro, water, philic, kind of into it, digging it, and phobic, afraid of it. So like a phobia, right? So if you're afraid of water, then you're friendly to fat. So if you're hydrophobic, you're going to cross the blood-brain barrier. You'll be able to cross a fat membrane.
Correct. And there's two hydrophilic statins, which mean they don't cross the blood-brain barrier. Rosuvastatin is one of them. So patients with ApoE4, I'm much more likely to go with a statin that's not going to cross the blood-brain barrier. And then with somebody who has a high genetic risk for myopathies, I'm thinking about usually pitavastatin or pravastatin is the other one that tends to have a lower risk of myopathy as well.
Love it. So nuanced decision making around which statin for which kind of patient that could incorporate their family history of cognitive decline, their ApoE status, their risk for myopathy, maybe their own pharmacogenetics, depending on whether there was something valuable there. There is some trial and error that's still associated with this, right? Yep. You end up doing your very best to come up with which statin you're going to recommend, and then they get myopathy on that statin, and you're going to probably switch to something else. I said it was the last question, but talk to me real quick about CoQ10 supplementation and myopathy.
Why not? You know, I mean, there's papers to suggest that it works. There's papers to suggest that it doesn't work. It probably is somewhere in between.
Pretty harmless, though. Right.
It's extremely harmless. CoQ10 is extremely harmless supplement to take. The only thing you really have to worry about is additional cost associated with it. I think that in my experience, there has been some benefit with some patients, so I often recommend it, especially if somebody has an increased risk for myopathy. And my guess is the reason that that some studies have shown a positive benefit and some have not is because there hasn't been a good study that's looked at those patients who have an increased risk for myopathy. Do they benefit from CoQ10 supplementation? And my guess is the answer is yes to that, but obviously there's no study to prove it. So I think it's one of those things like, you know, why not try it? Hopefully it helps.
Love it. Hey man, thank you. Appreciate it.
Thanks, Mike.
I feel like I know more every time I talk to you.
I love it when you call me with these super exciting topics. One day you're going to give me a call and you're going to be like, hey man, you want to talk about something like new and amazing, like, I don't know, psychedelics and their new use in healthcare, or like why Justin's honey peanut butter is so amazing or something like that instead of cholesterol.
I'm definitely ready to do a podcast any day about Justin's honey peanut butter. You know that if it's peanut butter related, I'm in. I'm going to give you a break from the atherosclerotic cardiovascular disease for at least 2 weeks. Okay. And then we'll reconvene. All right, man. Take care.
Thanks, Mike.
Thanks so much for listening to the Wild Health Podcast. If you're a Wild Health patient, you might not know, but you have access to our referral program. This gets your friends and family 25% off Wild Health services. Just head to Clarity, and in the top right corner, you'll see Refer a Friend. Click there, and you'll be brought to a page with your referral code. Happy sharing.